Hello and welcome to the lecture on pneumonia pharmacotherapy from an antimicrobial stewardship perspective. These are our objectives for today's talk. First, we'll start off with a couple of patient cases. Miss AP is a 66-year-old female who's been at the hospital for a month and a half following a hip replacement. She has a history of osteoarthritis and type 2 diabetes. She develops a new cough, shortness of breath, and sputum production. Her axillary temperature is 37.6, and a portable chest x-ray shows that she has a right lower lobe consolidation, and her oxygen saturation has dropped to 89% on room air. So you're asked for advice on the optimal pharmacotherapy for Miss AP. Secondly is our case Mr. HS. He's a 77-year-old male who was admitted to the hospital a week ago. He was previously at an acute care facility being managed for a prosthetic joint infection for which he had a surgical revision and received IV cefazolin for 6 weeks. His past medical history is significant for coronary artery disease. On admission, his MRSA screen is negative and he has had no history of MRSA infection or colonization. This morning, his oxygen saturation has dropped to 77%, and he's become acutely confused, febrile, and was refusing his morning medications. A chest x-ray shows a diffuse left lower lobe infiltrate that was not previously visible on the last imaging. So you are asked for your advice on how to manage the pharmacotherapy for Mr. HS. And again, we'll come to back to this at the end of the session. So pneumonia presentation and diagnosis is typically based on a constellation of signs and symptoms as well as radiographic findings. Signs and symptoms common in pneumonia would include cough, sputum production, fever, and focal respiratory abnormalities, but on their own, those signs and symptoms are generally inadequate and nonspecific enough to make the diagnosis of pneumonia. So they need to be done in combination with radiography, including generally a chest x-ray. So we're looking for typically patchy infiltrates or consolidation on the chest x-ray to indicate that the patient has a bacterial infection of the lung. In terms of organisms that can cause pneumonia, there's a wide spectrum of them. In the community setting, viruses are actually the most common causes of pneumonia, but followed by that, the most common bacteria would be Streptococcus pneumoniae, followed by H. or Haemophilus influenzae. In the hospital setting, Staphylococcus aureus and enteric gram-negatives would be more common. Also in the hospital setting, we need to worry about more difficult to treat organisms, and those would be based on patient risk factors, including recent hospital stays, as well as recent antibiotic use. In terms of sputum cultures, patients from the community generally don't need to have sputum cultures done unless we're really worried about more resistant organisms. But in the hospital, it is recommended that patients do receive sputum cultures, usually via a non-invasive approach, but this is based on low-quality evidence. In terms of Hotel du Shaver, which is generally kind of sits between community and the hospital setting, we would generally err towards the side of community in terms of which organisms will cause an infection and our approach to the sputum culture. But then we should also risk stratify based on the patients presenting to us. If they've had a lot of acute care stays, a lot of resistant organisms, or antibiotic use, then we would probably shift more towards the hospital side and be concerned about those organisms. Here's a nice chart that kind of shows the different antibiotics that cover various organisms. And here in the purple box shows you the typical organisms that might cause pneumonia. It's helpful to note that Streptococcus pneumoniae, being one of the most common causes of pneumonia, is quite nicely susceptible to beta-lactam antibiotics. So amoxicillin and ceftriaxone, Streptococcus pneumoniae is about 95% or more susceptible in the Hamilton, Haldimand, Niagara, Brant region. So reassuring to note that those antibiotics, those beta-lactams, can be reasonably used empirically for Streptococcus pneumoniae. So our recommended options for antibiotic therapy would be typically to use oral whenever you possibly can. Amoxicillin clavulanate is the first line option for pneumonia, with or without azithromycin. And we would consider using azithromycin generally if the patient has a suspected Legionella infection And in those cases, the patient would generally be more severely ill and have some risk factors like a recent history of travel, a known contact related to a Legionella outbreak, or infection during the months between June and October. And patients who have aspiration, that's a suspected aspiration, things like swallowing difficulties, a recent stroke, dementia, or witnessed macroaspiration, we generally would not need to use azithromycin. If those patients have beta-lactam allergies that are severe, generally we would not use amoxicillin clavulanate and defer to using levofloxacin as a second-line option for patients with allergies. In terms of intravenous antibiotic therapy for pneumonia, the first-line recommendation would be the use of ceftriaxone, with or without azithromycin, based on the similar caveats that we gave in the last slide. And an alternative for patients with beta-lactam allergies, we would consider using levofloxacin. It's important to be able to distinguish between aspiration pneumonia and aspiration pneumonitis, as those two entities are treated quite differently. Aspiration pneumonia is generally an infection of the lung that's caused by aspirating material into the lung, and it's usually caused by oral anaerobes, typical pneumonia organisms. The optimal treatment for aspiration pneumonia is using a beta-lactam and a beta-lactamase inhibitor or a cephalosporin because they generally cover oral anaerobes. But adding drugs like clindamycin or metronidazole that cover gut anaerobes is generally more than needed and it adds additional toxicity. For aspiration pneumonitis, this is usually caused by aspiration of gastric contents into the lung, which causes a very quick chemical irritation and does not result in an infection. So these patients may quickly resolve spontaneously within 24 to 48 hours. The optimal treatment for these patients is supportive and no antibiotics. So if you note that your patient has initially a suspected aspiration event and they're started on antibiotics and look better quite quickly afterwards, it may be something to reconsider the use of antibiotics and stop them early in those patients. If the patient has risk factors for drug resistance, this is where we want to consider using different agents than the ones we talked about as first-line agents. So if the patient has had a recent acute care hospital stay for greater than 5 days in the last 90 days, and or they've had received intravenous antibiotics in the last 90 days, then they're more at risk for more extended spectrum of different pathogens, including enteric gram-negatives. So piperacillin tazobactam would be a first-line option for those patients, and then adding vancomycin only for those patients who have a recent MRSA history or have suspected or proven MRSA infection. In terms of how long to treat pneumonia, generally 5 to 7 days is considered reasonable. Guidelines really indicate that 5 days is appropriate for patients who have shown a resolution of their vital sign abnormalities, including their heart rate, respiratory rate, blood pressure, oxygen saturation, and temperature, as well as their ability to eat, and they're back at their baseline mentation. Longer duration may be required if the patient has a lung abscess or an empyema. So let's get back to our patient cases. Our 66-year-old female, Miss AP, who's been at the hospital for a month and a half and has what appears to be a pneumonia, was the most reasonable option for her. She doesn't appear to have any allergies. She does not appear to have any recent hospitalization or resistant organisms, so it is appropriate to start her with amoxicillin clavulanate for 5 days if she's improved. For Mr. HS, who's our 77-year-old male with a little bit more of a severe presentation of pneumonia, he has had a recent hospitalization as well as recent intravenous antibiotics, so we need to be concerned about more difficult to treat organisms such as Pseudomonas. But he does not have any risk factors for MRSA. His MRSA screen is negative, and he has no history of MRSA infection or colonization. So for him, it's appropriate to start him on piperacillin tazobactam and then reassess how he's doing. So take-home messages for today's talk. Pneumonia, both community-acquired and hospital-acquired, can be caused by a wide range of bacteria and even sometimes viruses. Selecting the right antibiotic is dependent largely on patients' risk factors. Patients with aspiration pneumonitis and recovery in 24 to 48 hours really probably don't benefit from antibiotics. And the optimal antibiotic duration can be as short as 5 days in those who have improved. For some other references, if you would like to continue reading on this, I would recommend taking a look at the Infectious Disease Society of America guidelines for the management of community-acquired as well as hospital-acquired pneumonia, as well as the guidelines from the University Health Network Sinai Health System. Thank you very much for your attention, and we'll talk to you in the next lecture.